Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
So welcome to the latest videocast for the Medicine Journal. My name is Albert Ferro. I'm a clinical pharmacologist and I'm chair of the editorial board of Medicine. I'm delighted to be joined by Dr. Andrew Hitchings. So welcome, Andrew.
Thanks, Albert. Nice to see you again.
Nice to see you. And you say again because you did one not that long ago, actually.
Indeed.
So you'd better introduce yourself again and say who you are and what you do, because some viewers may not have come across our previous recording.
Yeah, of course. So yeah, I'm Andrew Hitchings. I'm like you, I'm a clinical pharmacologist. I work at St George's, University of London. I'm a reader in clinical pharmacology there, and I'm also a consultant on the neurointensive care unit. So my clinical pharmacology roles are centered a lot around education. I run the final year exams for the medicine program. And then quite a lot in medicines management. So I chair a formulary committee for Southwest London. I'm chairing a new and quite interesting new committee for NICE, evaluating antimicrobial drugs. And yeah, my NHS work is as a consultant on the neurointensive care unit, where I'm also the joint clinical lead. So look after patients who've had brain injuries, strokes, spinal cord injuries, and so on. And of course, a lot of general intensive care that goes alongside that. And I guess I should probably say at this point that although I'm a clinical pharmacologist, I'm not a toxicologist. And as I'm sure you're about to introduce, we're going to talk about the toxicology chapter or the poisoning chapter. But I should say I'm not a toxicologist, but I do still deal with a lot of drug toxicity because, as I'm sure we'll talk about, it's very common.
Absolutely. And I think it's important to say that we're doing this recording because the current issue, as you say, is on poisoning. And the journal is very much aimed at the general physician anyway. So it's what the general physician needs to know for working in GIM and also in revising for postgraduate general medical exams as well. So the kinds of stuff that's going to be covered are the common poisonings, the general principles of management of poisonings, and some important poisons that it's important for people to be aware of. Of course, there is the more specialized stuff, and the National Poisons Information Service is there to advise on all of that. But I think it'll be good to just visit some of the issues that are in the journal. Maybe we'll talk about one or two things that aren't in there, which are of interest as well. And obviously, as you rightly say, you'll be looking after some of these kinds of patients on the intensive care unit. So it'd be interesting to hear your perspective on some of these issues. But anyway, so we thought we'd start off with something around serotonin toxicity. So I'd be interested to hear what you think about it. It's obviously something that people are aware of in the context of particular, antidepressant type drugs. But actually, there's a lot of drugs that can cause serotonin toxicity, aren't there?
Yeah, absolutely. Yeah, I think serotonin toxicity is actually quite common and quite underappreciated. So there's the sort of prototypical examples of serotonin toxicity where someone has taken an overdose with a serotonergic drug, commonly an antidepressant, of which I'm sure most of our readers and viewers will know the tricyclics are particularly worrisome. And the poisoning chapter gives great accounts of the clinical features of serotonin toxicity, antidepressant overdose, and how that should be managed, which, as I say, is really important, particularly for things like tricyclics, which can be very dangerous. But actually, I think serotonin toxicity is is even broader than that. So there's as you allude to, there's a wide range of drugs that can cause serotonergic effects. So the antidepressants will primarily be working by interfering with serotonin reuptake at the synaptic cleft. But it's not just antidepressants that can do that. There's also the herbal products such as St. John's wort. There's recreational stimulants like cocaine and ecstasy. And then there's other prescribed medicines like tramadol. Tramadol are really widely used opioid analgesic that is augmented with serotonin and noradrenaline reuptake inhibitory effects. So it's actually quite a strongly serotonergic drug. And then there are drugs that can have serotonergic effects through other mechanisms. So there are drugs that can increase serotonin release, like amphetamines. There are drugs that can have direct agonist effects on the serotonin receptor, like fentanyl, which we use a lot of in the ICU. So taking all of those together, we've got really quite a large and diverse set of drugs that encompass prescribed antidepressants, other medicines that are prescribed for diverse indications, including particularly pain. We've got the recreational stimulants. We've got herbal products such as St. John's wort. And this means that you can come across serotonergic toxicity in quite diverse contexts. So yes, of course, you can have the patient with the antidepressant overdose, in whom it's maybe self-evident, but then you'll also have other poison patients, such as those who have taken a stimulant, who may have come in with a different medical presentation, like psychosis, or maybe with chest pain from cardiac ischemia or something, where actually serotonergic toxicity is also part of the clinical picture, but maybe isn't recognized. And then particularly of interest for me is the iatrogenic scenarios. So if we think about the kind of patient that we might have in the ICU, who might be on a whole range of serotonergic drugs for perfectly appropriate reasons sometimes. So maybe they were already on an antidepressant, which we've continued because we don't want to stop it abruptly. And maybe for whatever reason, they've been started on tramadol as an analgesic, and then perhaps they've ended up getting intubated for some reason, and then we're giving them fentanyl as an IV opioid as part of sedation management. And then we see that they're a bit pyrexial and they're a bit agitated, and we assume that their pyrexia is from infection, and so we give them antibiotics, and we assume that their agitation is because of some other thing, not recognizing that it may be part of serotonergic toxicity. And so then they end up getting more sedation. Maybe they get beta blockers to deal with their tachycardia and so on. And you can easily see how you end up really chasing your tail, starting a whole load of drugs to maybe you don't appreciate, or maybe we don't appreciate that we're actually starting drugs just to treat the side effects of other drugs, which could be serotonergic type side effects.
So I think the point you're making, which I think is really important, is that it's important to think of it that when you see a patient there with fever and tachycardia and all the other features, it may be something to think about. They may be having serotonin toxicity there.
Yeah.
So important to think about it, to recognize it, and perhaps know a little bit about its management as well. I mean, it's obviously something you deal with quite a lot. So could you just tell us a little bit about the management of serotonin toxicity?
There are two ways of looking at this. One is about treating the serotonergic toxidrome, as it were. And then the other, I guess, is thinking about the drug that's causing the serotonergic effects. So for example, I alluded already to tricyclic antidepressants, which are really potentially quite toxic drugs in overdose, and have some very specific management considerations, which the article on antidepressant poisoning talks about. And I guess important things to highlight would be the importance of clinicians getting an ECG, looking at the QRS complex, and if there's a broad QRS complex, you treat that with sodium bicarbonate. And And then I guess the other aspect of it is just thinking about the serotonergic toxicity, which as we've talked about, is going to manifest with things like agitation, tachycardia, and so on. So benzodiazepines would be a specific part of management of that, and of course just recognizing the drugs that are causing it and withdrawing them if possible. And as I say, they may include drugs that the clinicians haven't thought about, such as tramadol, fentanyl, and so on, in addition to obviously the antidepressants.
Great, thank you. You mentioned an important word there, I think, toxidrome, the serotonergic toxidrome, and I might just sort of bring you onto that if you don't mind, just to say a little bit about what that means and why it's useful to think about toxidromes.
Yeah, I think that's a really important concept in toxicology. And this term toxidrome is used basically to describe the syndrome. So by syndrome, obviously, we refer to a collection of signs and symptoms. So the syndrome that is associated with toxicity with a particular type or group of drugs. And there's an article in the chapter by Aidan King and Ruben Thanakody that has a nice figure that illustrates the common toxidromes, setting them out according to the effects of the drugs on things like body temperature, pupils, heart rate, respiratory rate, mental status, and so on. And this is useful because it helps us to identify the type of toxin, and then importantly related to that, the treatment that the patient's likely to require, because at least some elements of treatment are going to be common to the drugs that cause that toxidrome. So, for example, if you have a patient with small pupils, reduced level of consciousness, and a slow respiratory rate, then you're going to suspect opioid toxicity. So it's the opioid toxidrome. And the treatment's going to be with an opioid antagonist. Naloxone would be what we would use. But on the other hand, if you have small pupils, but this time associated with cholinergic features, so things like bradycardia, active bowel sounds, secretions, sweating, then in fact you might be dealing with the so-called cholinergic toxidrome. And the treatment with that is not with naloxone, it's with an anticholinergic drug, such as atropine. And I think that in itself is an important practice point, that not everyone, and not even every poisoned patient who has small pupils necessarily has opioid toxicity. There are other things that can cause it, and so certainly much rarer, but should probably have in mind cholinergic toxicity as another cause of altered mental status with small pupils. It's not always opioids.
Mm. Interesting. It's an important point. We don't really talk about this, I think, in the issue, but obviously there are the rare cases of nerve agent poisoning, aren't there? And
Yeah.
one thinks of Novichok a few
Yes.
years back,
Yes.
sarin in Syria, and so forth. Yeah. So the sort of thing that physicians won't necessarily come across very commonly, or even at all, but
Yeah.
important to recognize these things, isn't it?
Absolutely. Yeah. Yeah. I mean, hopefully none of us will see a case of nerve agent poisoning, but we can't ignore the fact that some of our colleagues have done. As you say, in Salisbury, not that long ago, we had there were several people unfortunately poisoned with Novichok, and then of course on a global, from a global perspective, there's the use of nerve agents as part of chemical warfare, sarin, as you say, in Syria. So yeah, so I think sadly, I think if we're involved in looking after people who are coming in at the front door with acute or critical illnesses, it's not completely outside the realms of imagination that we might come across cholinergic toxicity, which could include due to poisoning with a nerve agent. And as I say, some of our current peers have had exactly that experience, and in fact, they've published their experience. There's a nice article describing their experience of treating the Salisbury cases, and as I say, with or as you said, rather, the medicine chapter doesn't particularly deal specifically with with chemical weapon usage, but it does have an article on the management of poisoning with pesticides, which includes the organophosphate pesticides, which describes the principles of management and the kind of clinical features. So I'd definitely suggest that our viewers and our readers have a look at that article first, but then after doing that, the published accounts of the Salisbury cases make for really quite sobering reading. And yeah, we can talk through briefly what happened with those patients, because it is instructive, I think, if there's time to do so.
I think we could certainly do that. Yeah, absolutely.
Yeah. So, well, yes. I mean, so obviously, I won't. The names of the patients are in a matter of public record. I won't mention them here, but certainly they're in the widely reported in the media as our viewers and readers will know. But essentially, the first two patients were found unwell on a park bench, I think on a Sunday afternoon in March 2018. And the first responders, the paramedics, and then the clinical staff in the hospital to which they were taken in the emergency department and then in the ICU, they presumed that they were dealing with opioid toxicity for reasons that we were just talking about. It's entirely understandable. I'm not in any way criticizing them, because they had features of the opioid toxidrome. They had small pupils and they had altered mental state, and if you put it crudely, common things are common. So it's perfectly reasonable that they were thinking along the lines of opioid toxicity. But there were also features that are atypical for opioid toxicity. So they were having to repeatedly give them antimuscarinic drugs to treat bradycardia, which of course is exactly the treatment that they required, although they didn't. I don't think they recognized why they were needing to give it at that time. And it was actually only on the clinical handover the next day, on the Monday afternoon, when there was a fresh set of eyes who came in. And I think by that stage, a bit of a heightened sense of suspicion, and a clinical appreciation of what features fit into what toxidrome. And collectively, that sparked the idea of cholinergic toxicity due to organophosphate poisoning, was what they were thinking at the time. And of course, as we know, that was essentially ultimately found to be the case. It was poisoning with the Novichok class of nerve agent. And it was the recognition that the patients had cholinergic toxicity that then led to them being given treatment specifically for that. So regular administration of antimuscarinic drugs, an oxime drug as well. And they actually consumed the hospital's entire supply of atropine within 24 hours of starting that. But fortunately had good supply chains, which were able to keep them replete. And that led to a dramatic change in the clinical course for those patients. And those first two patients ultimately went on to make a good recovery. But sadly, as you and our viewers will know, there were then two further people who were poisoned with the same drug, just by unfortunate coincidence, if that's the right word. I think they were inadvertently contaminated with it, and sadly, one of those patients did die. And actually, as I was looking things up in preparation for our discussion today, I saw that the preliminary hearing for the public inquiry for the death of one of those individuals, that's going to take place just this week on Friday. So timely as it happens.
Yeah, definitely. Well, it's certainly a salutary lesson, isn't it? As you say, common things are common. Why would you think about stuff like that? But also, just to say, as you very rightly point out, if the clinical features are they don't quite fit the toxidrome and they fit something else, it's important to sort of look at the whole picture. So really, really interesting stuff there. Coming back to toxidromes, and maybe another thing it might be worth saying a few words about is the anticholinergic, not so much toxidrome, because we're not necessarily talking about toxicity. Well, we're not talking about poisoning as such, but we're talking about the fact that a lot of patients, particularly elderly patients, do get therapeutically prescribed drugs which have anticholinergic effects. There's now this concept of the anticholinergic burden of drugs, and that's something
Mm.
that's really come to the fore, isn't it, in recent times?
Yeah, yeah. So yes, I think as you allude to, there's two aspects to this. One is poisoning with anticholinergic drugs, producing the anticholinergic toxidrome, which is essentially the opposite to what we've just been talking about in terms of the cholinergic toxidrome. As you'd expect, pharmacologically, it's the opposite effect. So instead of having small pupils, they have dilated pupils. Instead of having bradycardia, they have tachycardia. Instead of having active bowel sounds and secretions and sweating, they'll have dry skin, dry mucous membranes, reduced bowel sounds, may even be in urinary retention. So that's the anticholinergic toxidrome, which we probably don't come across all that often, to be honest, do we? I guess it could happen iatrogenically if someone had an atropine overdose, and it is it's potentially conceivable that you could see toxicity from plants in the deadly nightshade family, belladonna, that would cause that. But I mean, it's important to think about and have awareness of, but probably we're not going to see it very often. Whereas I think what you're really getting at in your question is not so much the frank toxicity, but the side effects, the adverse effects that can occur with the diverse medicines that have anticholinergic effects, medicines that may all be prescribed with the best of intentions and using a correct standard dose, but they have a burden of adverse effects. And where those adverse effects fall into that anticholinergic group, then you have the collective burden of all the medicines that they're on with anticholinergic effects. And that has important, maybe subtler, but really important consequences for the individual. So it can affect cognitive function, it can affect bowel and bladder function, it increases the risk of falling, and a multitude of other things that, for people who are susceptible to those effects, and those particularly you're thinking about older adults, can have a significant burden and morbidity. And as you say, it's the recognition of that has led to the development of these criteria to quantify the burden of anticholinergic side effects or drugs. Beers criteria, I think, is one of the commonly used ones, isn't it? And that that in turn can lead to some rationalization of the person's medicines with the intention of reducing the anticholinergic burden and the side effects that are associated with that.
Yeah, absolutely. Thank you. Maybe to finish off, because we've sort of gone on for a little bit now, we should talk about one of the most common and important overdose situations, and that's with paracetamol. And important not just because of its commonness and its seriousness and so on, but also because the guidelines on how to treat it keep changing, don't they? I mean, we've got the more recent guidelines. Perhaps you could tell us a little bit about current thoughts on how to treat paracetamol poisoning.
Yeah. Well, as you say, it's probably one of the most common, well, is, I'm sure, undoubtedly the most common toxicological presentation to emergency departments, and it's really important because paracetamol poisoning is horrible, isn't it? It can cause liver failure and it can cause death if not correctly and promptly treated. But on the other hand, with appropriate treatment, we can be pretty assured of a complete recovery if it's treated early enough and with in the correct way. And we have that assurance of a reasonably good outcome, or good outcome in most cases, because we have a highly effective antidote, which is, of course, acetylcysteine. And most people watching this, I'm sure, will be familiar with acetylcysteine and its mechanism of action. But just briefly to recap, it's a drug that works by replenishing stores of glutathione, which protects the liver against injury from the toxic metabolite of paracetamol, which is produced in particularly high concentrations in overdose. That's N-acetyl P-benzoquinonamine, or NAPQI, as it will often be abbreviated to. So it's a very effective overdose, very effective antidote, I should say. But the problem with acetylcysteine is that traditionally it's been administered with a very complicated dosage regimen. And I think it varies between countries, but I think all of the regimens are fairly complicated in some way, even, and maybe the fact that they vary just adds to that complexity. But in the UK, traditionally, and in fact still the licensed regimen, is 3 sequential infusions of weight-related doses that are given over 21 hours. And this is a regimen that's prone to error because of its complexity, but also notably, it delivers half of the total dose in the first 1 hour. And actually, it used to be even faster than that, didn't it? It used to be 15
Yes.
minutes up until 2012. And acetylcysteine, though a great antidote, is not free of adverse effects. So it will commonly cause nausea and vomiting. And then for not an insignificant proportion of patients, it causes an anaphylactoid reaction. So that's something that looks clinically like anaphylaxis, but it has a different mechanism, and it's a dose-related phenomenon. So it resolves when the infusion's stopped. But as I say, it's dose-related. And so infusing such a significant proportion of the dose over such a short period leads to high initial plasma concentrations with a high risk of adverse effects. And so we've all seen patients feeling pretty sick on acetylcysteine, and that's, I guess, is what was the stimulus for a group of toxicologists in the UK to come up with an alternative way of infusing acetylcysteine that was intended to deliver the same total dose, actually over a shorter period, so 12 hours rather than 21 hours, but importantly, it's smoothed out a bit. So you don't have that really high initial dose that causes so much of the adverse effects burden of acetylcysteine. And that regimen, which goes by the acronym SNAP protocol, it certainly significantly reduces adverse effects by a clinically meaningful amount. And it's probably associated with similar clinical efficacy. I mean, pharmacologically, you'd expect giving the same dose over a slightly shorter period, it should produce the same effect. And there's reasonably good, at least observational evidence of equivalent clinical efficacy. The reason I'm slightly caveating this is because actually the original study was not powered to show non-inferiority. But I think evidence has accumulated in part through experience, in part through observational data, that has led the clinical community to develop confidence in this new way of administering it, which we know is better tolerated by patients. And that has been increasingly adopted, I think, by UK hospitals. I mean, this is happening sort of incrementally, I think. I would say in Southwest London, we've only in the last couple of years switched to this SNAP protocol. So we may be at different stages in different hospitals and NHS trusts across the country. But I guess that's why it's important to highlight that there could be this move to using a different regimen that is simpler to calculate, simpler to prescribe, reduces adverse effects, probably has the same clinical efficacy, but we're at different points in the journey of transitioning to it. And I guess I should, out of completeness, just point out that it isn't actually licensed. It is something that has the confidence of the clinical community. It is endorsed by the National Poisons Information Service, but it isn't actually the licensed regimen. And so this is definitely not something that individual clinicians should just be making decisions to use for individual patients, or indeed something that departments should just be changing to at a whim. It's something that needs to be worked through carefully with the formulary committee of the trust, or whatever equivalent governance structures an individual NHS trust has, just to make sure that transition is done safely, effectively, transparently, and with all the necessary procedural approvals. As I say, not something that should be individual clinicians should be doing.
Totally agree. And obviously anything that makes administration of medicines like this easier must be a good thing, so long as they're equally effective, which, as you say, the evidence seems to suggest that it is. Thank you, Andrew. Well, I think we'd better stop at this stage because we've gone on. I would just refer watchers of this video again to the June 2024 issue of Medicine, which will cover a lot of what we've been talking about today and other things as well. So please do go ahead, go away and read that issue. Andrew, it's been a pleasure. Thank you very much again for talking with me today.